Hello and welcome everyone to this virtual global report launch of the ILC's Delivering Prevention in an Ageing World programme. Next slide, please. My name is Kate Pierpoint and I'm the Head of Projects here at ILC. And if you don't know us, the ILC is the UK specialist think tank on the impact of longevity on society and what happens next. Thank you all for joining today. Next slide, please. We know that there's a clear health and economic benefit to investing in preventative healthcare throughout people's lives. However, despite repeated commitments to prioritise prevention at the G20 level, action continues to lag. So today we're going to be discussing two new major pieces of research. The first, a window of opportunity, which explores what good looks like across the world and what can be done to prioritise prevention, particularly to tackle inequalities, use technology and inspire and engage healthcare workers and policymakers. And a second, we have a report called Doctor's Orders, looking at why adherence is critical to improving health outcomes across the life course. So this programme, the prevention programme, has been made possible by charitable support and grants from Amgen, Home Instead, GSK, Gilead, MSD, Pfizer and Seqirus. Doctor's Orders is supported by Amgen, which is an international pharmaceutical company with a strong interest in health systems strengthening, particularly in areas that relate to non-communicable diseases. I'm excited to be joined by an absolutely stellar panel of experts across the world today. Thank you all for joining us. They will be offering their responses to the findings and recommendations of the reports. And we'd also like to hear from you in the Q&A section. We'll be having a panel discussion, so feel free at any point to add your questions to the Q&A function at the bottom. Next slide, please. Before we get started, there are just a few housekeeping rules to go through. The first, this is quite exciting. We're doing two parts of a poll. So we'd like you, please, if you do have a moment, to join at that website and then tap in the number there, fairly simple number, and then just give a brief answer as to what you think the biggest opportunities for change in this field are. And when we have the first panel discussion, we'll bring up a word cloud and we'll discuss around
systematic issues in the countries. When we talk about, for example, the guiding principles for recovery, etc., I think this is an opportunity
to ask panelists to mute.
To hear about some countries that could.
Great, thank you very much. At the bottom of your screen, you'll see a chat function and you can communicate directly with panelists and delegates, as well as the Q&A function. So as I said before, please do put in your questions and we'll come to them at the end. You're also invited to post comments on Twitter using the hashtag Delivering Prevention and are at ILC UK. This webinar will be recorded and published for public access on our website and YouTube channel, and the presentation slides and the recording will be published tomorrow. Great, so that's enough from me. So first, I'd like to begin by introducing Naokeyamamoto, who is our research fellow at the ILC. She will be presenting the case for prevention, adherence, and opportunities for change. Welcome, Erin.
Thank you, Kate. Can I have the next slide, please? Great. Following our Prevention in an Aging World program, it became strikingly clear that there was a consensus among world leaders that prevention works, it's cost effective, and that its benefits extend well beyond our healthcare systems. But what wasn't so clear to us was how we can move from recognizing its importance to understanding how we can actually reorient our healthcare systems towards prevention. Excuse me. And then the pandemic happened. It has both exposed and amplified health inequalities, demonstrating a real need for prevention, but it has equally shown how quickly governments can respond to safeguard our population health. While this is promising, there's no guarantee that these positive steps will continue in the long run. So we have a small window of opportunity here for us to not only demonstrate how governments can prioritize prevention, but how they can build lasting change after the pandemic. Next slide, please. So over the last 2 years, we've informed and shaped both national and global health policy, from being a partner on the UK's Department of International Trade's Healthy Aging White Paper to feeding into T20, which is a consortium of leading think tanks and academics that provide research-based policy recommendations to G20 leaders. We've also published a series of reports on a number of preventative health issues and responded to emerging health research and data, as well as hosting a number of webinars responding to emerging policy developments. Next slide, please. And throughout this, we've also engaged in a significant consultation process, speaking to over 80 experts from 75 different organizations from across the world to really understand the solutions to implementing prevention across the life course. Next slide, please. So as part of our Delivering Prevention program, we're also publishing our doctor's orders report on adherence. So getting individuals to adhere to medications for chronic diseases is a crucial part of the prevention agenda. We know that in an aging world, more and more people are going to be living with chronic conditions. Indeed, already nearly half of all adults worldwide have at least one chronic condition. But we know that much more can be done. Because adherence that currently is as low as 50% in high-income countries and even lower in lower-income countries. We've spoken to 10 experts from across the world, and the message is quite clear. We need a whole systems approach to tackle non-adherence, and the onus should not be placed solely on individuals. And we must ensure that adherence is prioritized, because inevitably we'll need to be ensuring not only that we can prevent conditions, but enable people to manage their conditions so that they can continue to become, to be productive members of society. Next slide, please. So if we want to invest more greatly in prevention, we also need to invest in systems that are designed for prevention. And this begins with structures and strategies for integration, including integration of health services. So this is across public and primary healthcare. And we need to involve actors that are outside of the formal healthcare system, including, for instance, NGOs. We also need a coherent policy approach to addressing ill health. While G20 governments have already implemented many strategies to address specific health conditions, they lack clear oversight and direction to address health issues that cut across, for instance, like preventative health. Governments must also include adherence requirements in national plans and put in place strategies to measure adherence to identify opportunities to intervene. We also have to do more to improve incentives across the system by incentivizing prevention. We need to move away from fee-for-service models where reimbursement is based on the number of services a healthcare professional provides, such as doing more tests or more procedures, because such payment models can actually serve to disincentivize preventative healthcare. And we also need to do more to prioritize pooling of budgets to support integrated healthcare systems. Next slide, please. Once we invest in systems designed for prevention, we can look more closely at how we can deliver prevention across our three key action areas we've identified as crucial to supporting the prevention agenda, starting with inspiring and engaging. Looking specifically here at the role that policymakers, healthcare professionals, and individuals have in investing, promoting, and taking action on prevention. And this begins at the international level through international accountability and incentives. We need clear direction and accountability from intergovernmental organizations like the World Health Organization. For instance, the WHO's immunization agenda for 2030 sets out really clear targets for improving vaccine coverage, but implementation at country level seems to fall behind. In addition, many of the WHO's targets tend to focus on pediatric vaccination rather than life course vaccination. So holding governments to account by having clear targets across the board for life course vaccination and other preventable diseases, including ranking how well they perform against these targets, can really help to encourage governments to take action. We also have to do more to unite prevention advocates. There's many strong advocates for prevention, and they play a key role in holding policymakers to account. But the health arena is crowded and full of opposing interests, or interests that appear to clash when in reality they don't. We need to do more to bring these voices together under a coalition for prevention. Healthcare professionals, of course, have a very important role to play in delivering healthcare, but we need to support our healthcare professionals' capacity in order for them to be able to do the work. The WHO predicted a global shortfall of 18 million healthcare professionals by 2030. These shortages pose a significant threat to the effective delivery of preventative healthcare, particularly for marginalized and underserved groups. Healthcare professionals need to be properly educated on the importance of prevention, and as well as education across the board. And this is also key in supporting medication adherence, as many healthcare professionals continue to lack the requisite skills and knowledge to support people with behavior change. We also need to do more to improve their working conditions, such as addressing burnout. Again, in our doctor's orders report, we highlighted that funding is needed for healthcare professional training and adherence interventions to ensure that healthcare professionals who are, by the way, already overstretched can properly support their patients. And we also need to involve the extended healthcare workforce to reduce pressure on healthcare systems and to improve health outcomes. Community pharmacists, for instance, are well placed to support medication adherence. They work in the hearts of communities and they understand the benefits, side effects, and risks of the medications that they dispense. So finally, individuals, they're also vital actors in prevention. We need to engage them with, we need them to engage with our healthcare systems. We also need to address public perception of public health and healthcare and the healthcare system. Marginalized communities are more likely to be distrusting of public health bodies, which can prevent them from accessing preventative health interventions. More needs to be done to build partnerships with trusted sources, such as religious institutions, ensure these approaches are embedded throughout healthcare delivery. We also need to look at the opportunities to influence individuals with health decisions. During the pandemic, we've seen countries doing their best to incentivize people to take the COVID vaccine, from lotteries to free food and books. But behavioral science techniques can also support individuals to adhere to medication for chronic conditions. Yet only a handful of countries have started to properly use it in healthcare and other policy domains. There's also a lack of consensus about around what actually works. And it's clear we must use tried and tested frameworks to ensure their effectiveness, because strategies employed to improve vaccine uptake is going to look vastly different to those supporting people to take medication on a regular basis to manage their chronic illnesses. Next slide, please. So our second key action area for delivering prevention is democratizing access to prevention by bringing down the barriers to accessing preventative healthcare. And there are several barriers that we need to address. For instance, economic barriers, such as co-payments for medications, can act as a significant barrier to adherence, especially when someone needs to take it over a long period of time, or if they're prescribed for more than one medication, the costs can quickly add up. There's also geographical barriers, such as living in rural and remote communities where there tends to be fewer health facilities and where people often lack access to affordable transport. And there's also knowledge barriers, such as low health literacy, and barriers facing social minority groups, such as ethnic minorities and migrant and transient populations. We also need to address needs across the life course. Older people are locked out of vital preventative healthcare interventions in too many countries whose health policies prioritize the needs of younger people over older adults. So to address these barriers, we need to provide prevention where people are, in their communities, in their shopping centers, their workplace and homes, really embedding it into people's day-to-day lives. We also need to provide person-centered healthcare, ensuring patients are equal partners in their own care. And this is certainly true if we want to improve adherence. Tailored adherence needs to be a focus of the healthcare system, and we need to ensure people's circumstances, their lifestyle, including the barriers that they may face, are taken into account, as these can all affect adherence. And we also need to take more targeted approaches to ensure community and population interventions meet the needs of individuals by co-producing interventions with patient groups and other actors and leveraging population health management. Next slide, please. And finally, our third key action of area for delivering prevention is using technology effectively. Technology can clearly play a crucial role in the prevention agenda, but there is a risk that we will come to see technology as a plug and play tool that can solve all health challenges. In reality, there are many barriers that prevent countries from unlocking its full potential. We need to leverage data analysis to support targeted services. We can use big data to help reduce health inequalities and improve health outcomes at the population level. There's a lot of data that could be useful to the prevention agenda, but much of it isn't joined up. And there are lots of underlying barriers to data sharing, including poor infrastructure or interoperability. We saw the effects of poor data interoperability during the pandemic when healthcare professionals were unable to adequately document patient status, leading to suboptimal care pathways, lack of trust between data provider and users, and data sharing costs such as money, time, and resources. We also need to do more to connect individuals to preventative healthcare, such as through the use of electronic health record systems. It's also a key facilitator in supporting adherence. For instance, it can allow individuals to take control and manage their own health, but it can also support healthcare professionals to view prescribed medications and have conversations conversations about adherence with their patients and take any necessary steps to change or reduce the burden of medication. But what we know is many records aren't linked up, nor are they electronic. And this is certainly true for vaccination records in many countries. We must also address digital exclusion and poor digital literacy by using lower health technologies. And we must ensure that there are enough opportunities for healthcare professionals to receive training on using technologies as well to support prevention delivery. We also need to be empowering individuals with user-centered technology. A wide range of technological innovations exist, from gamification to social media, and they can help empower individuals to take control of their health. But in many countries, the public are confused about having to deal with multiple systems for similar purposes and can discourage the public from using digital technology altogether. Countries can implement health technology assessment frameworks for digital solutions, which can help national healthcare systems make decisions on which technologies should be financed or reimbursed. They can also ensure that the right technologies, so those that take into account barriers to use, their effectiveness, that reduce duplication of efforts, and ensure that they actually solve real health problems, are adopted. Next slide, please. So I'd like to leave you with one final thought, is that if we really want to embed prevention across the life course and across our systems, we need to have this. We cannot have this without systematic change. If we don't have it, what we're going to see is we will continue to see our populations live with avoidable disability, our economies will continue to suffer as a result, and our governments and healthcare systems will continue to unnecessarily waste money and resources. Thank you very much.
Many thanks, Erin, for that presentation. Before we move on to our panel discussion, I'd just like to remind you all to just type in slido.com, and it's 1, 2, 3, 4, 5, 6, 7 in the sort of hashtag section, and then just to try and answer that question and submit it. It's quite easy, and we'll discuss after the panel discussion. So I'd like to come first to Garth Graham, who's the Director and Global Head of Healthcare and Public Health at Google and YouTube. Welcome.
Thank you. Thank you for having me. And first, I want to start off by acknowledging a lot of the points in the report and what I think that means for health and public health. The also interesting part is that recognizing that though the pandemic did unmask, or at least highlight, a lot of the inequities that we've often seen in lower socioeconomic, minority, and other disenfranchised populations. Those inequities have existed for so long and are so complicated on so many different levels that the opportunity we have now is potentially for change and to try to move forward, at least in an inch-wise fashion, in terms of things that we have learned and can do differently. The other thing is that the report, I would also like to highlight about the report, is that many of the thoughts and ideas around the report need not be mutually exclusive. And so understanding how we inspire and engage is very much related to the effective use of technology and very much related to how we democratize both information and access to care. And all of these things are not mutually exclusive, but actually, if we think about the concept of patient-centered care, really can allow us to emphasize the life course of an individual. You know, I often say that where you live should not dictate how long you live, but that is the case in when we think about global health in so many different ways. And a lot of my life's work around health disparities and health equity have, I think, taught me a lot about understanding what it is to have that patient journey and that patient experience and that community level experience that is so different, I think, many times depending on both the economics and so many social factors and social determinants of health. But going back to a couple of key points I want to emphasize from my standpoint, and then certainly as we get into the further panel discussion, the concept of the effective use of technology. Technology is a tool, not an end-all be-all. It's one of the many different potential tools that we have in our spectrum of improving the lives of individuals and communities. The other thing to kind of understand here is understanding that these tools need to be a part of the patient's journey, not on the side, not designed separately, but designed with communities overall in mind. And I think that is something that our team is very much dedicated to. I also believe in a concept of health literacy and information being a determinant of health, meaning we have to be able to engage communities with information that speaks to them and matters to them, and move information outside of the silos of academia and government and into dinner tables and couch conversations and into just the regular lives of people so they can understand and engage more in their own healthcare and public health. And then the last point I would like to say is that, you know, the pandemic gives us the opportunity to make public health really public. What does it mean? It means that for the first time, we have the proverbial microphone in terms of being able to engage so many different sectors of the world right now, not just the healthcare sector, because we're only one component of this dynamic, and not even just the technology sector, but understanding around housing, transportation, and all of these different ingredients that go along into an individual and community's healthcare and public health. So it's important for us to think broadly, utilize technology with the concept of the patient and the community at the focus. And then lastly, at the very end, measure ourselves in terms of outcomes and progress and feed that back into an integral loop to see where we are. Hopefully where we are this year is not the same place we are next year, is not the same place we are 5 years from now. I'll just close by saying, you know, the journey we're on is not an individual or even a country-specific journey. It's genuinely a global journey. And our goal and focus has to be the lives of communities, especially those who need it the most. I'll stop there.
Thank you very much, Garth, for those words. I'm going to move on now to Professor Julie Biles, who's the Director of the Centre for Women's Health Research from the University of Newcastle, Australia. Welcome, Julie. It's really very early in the morning where you are.
It's late in the evening, not yet early in the morning. Yes, so hi. So yes, so I wanted to talk about, because it's interesting that we're talking about the window of opportunity, because I talk about there being a wide window of opportunity and a long tail of prevention. So I'm going to talk about those two aspects and what I mean by those things. So if we can move to the next slide. So I'm going to start with some talking about these windows and tails using data from the Australian Longitudinal Study on Women's Health. So this is a study we commenced in 1996, and we had 3 cohorts of women at that stage, and the oldest were aged 70 to 75, and 12,432 women joined the study then. And if we take a representative 20 women and have a look at what they were like in 1996 when they were 70 to 75, around 36% or, sorry, I just moved my things here, I can't see what I'm saying, around 7 out of 20 women had no major disease that we were measuring and no significant disability. Around 8 out of 20 women had disease, a chronic disease such as heart disease or arthritis or diabetes, but they had no significant disability, and 5 out of 20 had significant disability such that they needed help with daily tasks. So we fast forward to when the women were 90 to 95, of course, a large proportion of the women had died, so 65% of the cohort had died, and only 4% of those who died had no disease or disability recorded in our data. Of those who are alive and participating in the study, now only 8% or 1 in 20 had no disease or disability. 6 out of 20, had disease but no disability, and 64% had disability. Now, it's these apricot women who have chronic disease and no disability. That's what I'm talking about as a wide window of opportunity. So even when women or men, but in this case our data are women, are in later life, and even when they have a chronic disease, there's still a wide window of opportunity where we can intervene to prevent disability, either by managing that disease better, preventing the onset of complications or comorbidities, managing comorbid conditions, or just improving their general capacity and supporting them where their capacity is maybe declining. So there's an enormous amount we can do to improve people's abilities. And then if we take the women in yellow there where they have disability, this is what I still talk about, the long tail of prevention, because even when people have onset of disability, there's a lot we can do to stop that disability progressing. We can sometimes regain abilities, and we can support people quite a lot right through later life and right up to and including a good death. Now, with these data from these women, we also did some other modelling. We used Markov models and looked at the predicted probabilities and the time in each of those states. So disease, disability, or no disease and no disability. And of course, death being the terminating state. And from 70 to 75 on average in the analysis, the women lived 8 years with no major disease or disability. They lived 4 years with disease and no disability, and 4 years with disability. So this 8 and 4 years of no disease or disability, or with disease and disability, that's our window of opportunity. And the 4 years with disability is our long tail of prevention. So there's really a lot we can do. And the reports, the various reports that have been put out indicate some of the things that we can do. But if we can move to the next slide, I just want to talk about some of the things that I think we're missing that we could be doing. So we could be doing a lot better in terms of the management of chronic conditions. And I've singled out diabetes here as an example where we know that in Australia, for instance, we're not doing nearly as well as we could be. So people are still losing limbs through amputation because their diabetes isn't controlled. They're still losing their eyesight. They're still losing function of their kidneys, and diabetes contributes an enormous amount to cardiovascular disease burden in Australia. But it could be managed so much better. So one of the things is we know there's a delay in diagnosis. We know that it's not necessarily monitored as well as it could be once it's treated. And we know that there's treatment inertia. So when people's glucose control, when their glucose is not controlled and their needs for medications increases, then medications aren't necessarily increased. So there's an enormous amount we could be doing to improve the management of diabetes in Australia. And of course, a lot of that is type 2 diabetes, which has a whole lot of lifestyle factors involved in the risk of that condition. So there's a whole sort of lead time there as well. We have preventive assessments for older people in Australia. They're very widely used. So at least 70% of older people will have had at least one assessment of their overall needs. So it's a sort of general geriatric assessment carried out by their family practitioner or a nurse based in the family practice. But we also suspect that whilst there's a lot of box ticking, maybe there's not a lot of action in response to ticking those boxes. So we need to look much more systematically at what's being discovered on those assessments and what could be done about them much more proactively. We know that exercise is a cornerstone of aging well. It's a cornerstone of managing a lot of chronic diseases. It's a cornerstone of preventing diseases and maintaining physical capacity and physical abilities. But we don't very often prescribe exercise for older people. We don't very often promote it, and there are a lot of barriers to older people exercising. But if we could put the benefits of exercise in a pill, we'd be sure to prescribe it. Unfortunately, it's easier than a pill, but harder for us to manage to get people to do it. We don't do very much in the way of restorative care. If people lose one ability, we just sort of prop them up a bit until they lose the next one and the next one, when in fact people can regain abilities either by regaining the functional capacity or finding a new way of doing things. And the last thing is something that Arun mentioned, is about empowering the people themselves to be responsible for their own trajectories through their later life. So be responsible for their own windows of opportunity and their long tails of prevention. So just to finish up, I just want to acknowledge that the data that I talked about comes from the Australian Longitudinal Study on Women's Health. and thank the Australian government for the funding and the women providing the data over all these many years.
Thank you very much, Julie. Very interesting to hear about the windows of opportunity, as you call it. Fantastic, thank you. I'd like to come next to Professor John Wenman, who's the Professor of Psychology Applied to Medicines and Director of the Centre for Adherence Research and Education at King's College London. Welcome, John.
Good, thanks, Kate, and thank you very much. Apologies for my voice. It's a bit croaky. I'm suffering with COVID at the moment, sadly. I just wanted to, well, first of all, congratulate you on a great report. I think the Doctor's Orders report is really excellent. It lays out the challenges, the adherence challenges really clearly, and a lot of the really important issues. And I think it comes up with really important recommendations. So congratulations on that, and thank you for involving me in the development of the report. I really, just following on and thinking about the report, really just wanted to draw attention to 4 sorts of issues on the next slide. So I think if we're thinking about a prevention perspective, which is obviously crucial, and thinking about adherence and medication adherence, there are 2 sort of quite distinct challenges I think maybe we should be aware of. Firstly, helping people take medicines which reduce their risk. And these are people with silent conditions, people with things like, high blood pressure, osteoporosis, and a whole range of conditions where the person does not feel bad themselves, but clearly is carrying a risk for which medication adherence could have a dramatic effect. And so preventing those risks of, say, going on to, say, strokes or falls and fractures and so on. So that's one area. There's a particular challenge about trying to support people with these so-called silent conditions. There's a real challenge there. Secondly, I think obviously, and we talked about this a bit, for this really large number of people with long-term conditions, ongoing conditions, the diabetes, arthritis, and so on in older age, medication adherence again has a massive, medication adherence has a massive risk reduction and prevention role. So what we're preventing here really are the exacerbations, helping people avoid the worsening of disease, the complications, the added hospitalizations, the surgeries, and so on. So I think that making that distinction is sort of important, because the strategies we might want to use and the perceptions of both healthcare professionals and public will vary across those 2. So just wanted to flag that. In terms of sort of where we need to go, I think I've got really 3 bullets. One is that we still need a much more complete understanding of the causes of non-adherence, why people become non-adherent at the different stages of treatment. Some people find it really difficult to start treatment, don't start treatment. They'll make a start, they'll get their medicines, but they find it really difficult to implement the treatment in the day-to-day course of their lives. And for another group of people, that might be okay, but they may have challenges in sticking with it over time. And that 3-way distinction, or those 3 phases, are important. And there are different drivers and causes of non-adherence at each stage. And we need a much better understanding, a much more detailed understanding of the different factors that drive or cause adherence challenges at each stage. The second thing I think we need to draw attention to really is that we need much more sort of patient and healthcare professional friendly ways of just picking up adherence and even risks of non-adherence in routine care. It's a sort of hidden thing in there. Clinicians often don't ask about it, patients don't talk about it, they often feel a little bit challenged. It's a rather difficult, it's a sort of contested area. And that people are finding it difficult to engage in. I think we really need something which is much more straightforward and that everybody, the patients and healthcare professionals, will feel happy in. And we've got various things that we're developing in our centre for that. And then crucially, everybody talks about, we've got to promote better adherence, but that's not necessarily straightforward. There are 1,000,001 interventions out there, huge number of studies, and most of them are not effective. The Cochrane reviews show they're pretty minimal in what the gains are, because they're not really that well developed from a point of view of being based on a really good understanding of what's causing the non-adherence in the first place, and secondly, not being tailored to individuals and individual needs. And that, you know, I think is where we're at. We really need to develop really good evidence-based support, adherence support, behavior change techniques, whatever we like to call them, to provide these much more tailored interventions for individuals via a range of channels. So it could be through a healthcare professional who needs to be trained, could be through digital, could be through, you know, much simpler channels, magazines and so on. You know, we really need to use that wide range of channels and help people in ways that suit them best. So they're really the 3 points I wanted to raise, but really come back and say, well done for a great report. I think it's hopefully going to have a really good impact in this area. Thank you.
Thank you so much, John, and really helpful to understand some of the challenges and issues around adherence. I'd like to move on now to, I think Emily is not here at the moment, but we may come back to her if she joins us a bit later.
I'm here.
Oh, hello, Emily. Nice to join you. Can I pass over to you?
Absolutely. Good morning from Omaha, Nebraska. It's wonderful to be with all of you virtually. Just a special thank you to ILC UK for convening us today and for all of your work around this program. Just hearing from the other panelists so far, it's clear the time and effort and talent that each of you put into this. I'd be remiss if I didn't thank Martin Jones, who's the CEO of Home Instead UK, for connecting us, Home Instead globally, to this opportunity and his collaboration on this work. I'd like to talk about how the elevation and the external transformation of the care workforce, as well as the traditional healthcare ecosystem, recognizing care professionals and relationship-based home care are key tenets to prevention. But before I jump into that, a few broad observations around the report itself. I appreciated how it didn't just admire the problem, but instead it was focused on solutions, tangible action to drive solutions. I also applaud how it focused on the importance of multi-stakeholder solutions. There's a saying, I'm not sure if it's global or if it's specific to the United States, so thank you for humoring me if it's the latter, but it's that rising tides lift all ships. And it's going to take all of us in all sectors to do this work together around prevention. These observations actually reminded me of a report that we released in collaboration with the Global Coalition last fall, entitled Building the Caregiving Workforce Our Aging World Needs. I'll put a link to that in the chat following my remarks. And it provides, in my mind, a perfect segue to a couple of thoughts around how elevating the care profession goes hand in glove with this work. While keeping older adults safe at home is a recognized priority for healthy aging, the value of the multitude of benefits it provides is simply unappreciated. Home care and care professionals play an important part in early detection as well as prevention of disease and decline. Home care streamlines transitions from hospital care to skilled nursing or rehabilitation facilities to the home. It maximizes choice for older adults. It allows them to follow their clear preference to age in place. It reduces hospital readmissions. It lowers overall healthcare costs. It alleviates a burden on loved ones of the older adult. But the status of these care professionals, it still remains low. So in order for us to deliver prevention more impactfully and effectively, healthcare systems, whether public or private, need to better understand and formally recognize the vital role that home care workers, care professionals play within the traditional healthcare ecosystem in order to grow a qualified and a talented workforce and elevated in the process, home care agencies and national governments and others, so that multi-stakeholder solutions must focus on and truly meet the needs of care professionals so they can more effectively and impactfully deliver prevention. I kept it short and sweet. Thank you very much. Thank you very much, Emily. That's fantastic and really helpful to understand the benefits of home care and how this fits in the wider picture. I'd like to now take us on to the results of the first poll, if our tech allows it. Hopefully this should look pretty cool.
Interesting. So thank you everyone for submitting your questions, submitting your answers to this. So this is what do you think is the biggest opportunity for change? And I think when we get to the panel discussion, it will be really good to bring this up again and to discuss this more fully. But a very interesting, obvious, clear winner there. Wonderful, thank you. I'd now like to introduce Lily Parsi, who is our Global Policy and Influencing Manager at ILC, to talk about our calls to action.
Thank you, and it's been really interesting to hear from the panel so far. And actually, I might end up repeating a little bit here, so I'll go quite quickly. So I think this is really the second section of our discussion today here, to think about how we move from what we know works, and there's been some really good examples so far, to actually making the case and making sure we see the action we need. So to quickly recap, we know prevention works, it's cost effective. There's lots of different ways and shapes it can come in. So be that sort of the more formal things within the healthcare systems like vaccinations and screenings, to, as others have alluded, really working with community organizations and so on. Prevention comes in different shapes and sizes, but it really works, and we need to be heading that way. We know that particularly in the context of an aging society where the potential burden of preventable diseases could be rising, and in the build back from COVID, where we have a lot of backlog, it's had a massive health and economic impact on different countries, we're going to have to be focusing more on prevention. The pandemic has really exposed and amplified health inequalities, but it's also shown us really how quickly governments can act, that there is investment there if it's needed, that we can act quickly, we can act in communities. Lots of different professionals came together to work together across different borders and boundaries, and that tech and data can really be leveraged in this area. So we argue that there's a small window of opportunity to really build on these learnings and make sure that we're continuing on from the infrastructure we build and build lasting change. So how do we do that? We know there's already been some progress. Prevention has really gone up the political agenda, partly as well during the pandemic, but we now need to make sure that we sort of go from it being a nice to have to really making it a need to have and making sure we're moving ahead beyond the pandemic as well. So we argue that to really kickstart any action in this area, we need to be investing. So the average across the OECD at the moment is to spend about 3% of health budgets on prevention. And we say that that's simply not going to cut it. We need to be investing more if we want to go from illness services, which primarily just treat conditions after they've occurred, to really preventing things and making sure people are empowered to manage conditions they already have and stay as healthy as they possibly could. So in our report, we're calling for at least 6% of health budgets to be spent on prevention. You can see here in this little graph, Canada already spends that. And while obviously we're not saying that everything's perfect there, we can see that since Canada adopted that spending target in 2010, they've seen big decreases in mortality, increases in life expectancy, and one of the lowest, one of the highest survival rates, I should say, for certain cancers across this group. So we know it really works, we know it pays for itself, and that it's achievable. So to take an example for the UK, reaching this target would be about 5% of what the government has spent on COVID-19 measures, and we know it's becoming urgent. Alongside this, we know we need plans. So some countries have already adopted prevention strategies. We think this should be part and really starting point for all countries really as they build back from the pandemic. And we need to make sure we're integrating services. So Aaron mentioned this previously, there are so many different actors involved in people's health that aren't just the formal healthcare system. So we need to make sure that we have formal national legislation that helps healthcare systems, public health, social care, and wider stakeholders really work well together. Part of what's going to enable that is making sure we're actually pooling budgets, so there aren't things that are just disincentivizing and in the way for people to work together. And when we talk about incentives, we need to make sure that the way we reward and pay for services isn't just based on each individual service that's going to be delivered, because that simply incentivizes people to deliver more services as opposed to focus on people's health and the outcomes that come. So we're calling for countries to adopt more value-based payment models that really focus on what's happening at a population level and how the people they're seeing are doing. Aaron mentioned this, we need to inspire everyone around this agenda. And to start off, we need to inspire policymakers who can make the decisions about budgets, but also the big picture system and structure level issues we've been talking about. And I think there's a real opportunity for organizations such as the WHO to really hold governments to account, incentivize action. We see here, for example, the COVID-19 dashboard that the WHO rolled out very quickly at the start of the pandemic, which really helped to kind of track progress and benchmark good practice. And I think there's a real opportunity here as well, coming back to the comments previously on adherence, to not just track how we're doing in terms of preventable diseases, but looking at how adherence rates are doing in different countries. For organizations like ourselves, but there are many, many others out there that are doing some excellent advocacy work, we need to make sure that our voices are united so that we're not pitching different conditions against each other or different countries, but we're really uniting around the key issues that there are. And I think even just from having heard a few people on the call today, there are some clear things we all agree on. We need to make sure we're coming at them with one voice, so we're arguing for the same things. In terms of healthcare professionals, during our consultation with different stakeholders over the last 2 years, one thing that really came out is that a big barrier for people to healthcare professionals to really have that sort of holistic approach to a person and think about prevention from the beginning to the end is actual time. And we know that particularly during the pandemic, we've had massive workforce shortages and coming out of it as well as lots of people who have simply been quite traumatized by the impacts of the pandemic. Burnout is at its highest ever levels. So we need to really, across all countries, make sure we're addressing healthcare workforce shortages and have strategies to improve working conditions and retention, or simply it's a non-starter. We think we should also be making use of everyone who's already there and has the skills. And we know that lots of healthcare professionals and allied healthcare professionals aren't really being used enough at the moment. So we've seen, again, for example, during the pandemic, pharmacists that were really fundamental to the COVID vaccine efforts. But at the moment, it's still only about 30 countries where they are allowed to administer vaccinations. So we need to be thinking much more sort of savvily about who we've got, what they can do, who's engaging where, so that it makes it really easy for individuals when they're already engaging with, say, a midwife, a podiatrist, they're already signaling them to the right places. We need to provide the right training. And I think here it's important to say we're not adding, another bit of training onto everything else that's there. But within everything that we're thinking about, it's about how can we equip healthcare workers to really promote prevention efforts, and how can we equip them to really know what works, for example, in helping people to adhere to medications or lifestyle regimens, because I think this is a really big, and Aaron mentioned it, a really big potential for where we can be saving resources so that people don't have to come back with either worse conditions or to come back for the same issues. And I guess it all comes back really to how do we inspire and engage individuals themselves to take up preventative interventions, to adopt healthier lifestyles. And I think it comes through all of this, but we need to make sure that everything is centered around the person. In terms of behavioural insights, I think we've mentioned this a few times, there's a lot of potential for nudges and incentives to help people either on short-term things like coming in for a vaccination or longer-term things. But the reality is we simply don't really know enough about what works yet. So we're calling on governments to establish behavioural insights teams to really research and test and publish the results of what works and what works for different people, so that can become part of our arsenal as we start thinking about public health. We need to improve trust, and I think Aaron touched on this very well already. We've seen, for example, during the pandemic, governments, healthcare systems working with local actors such as faith leaders and community groups. This kind of needs to become our bread and butter. We need to think about who people actually listen to. Very often it is their healthcare professional, but there might be other routes as well. And we need to use everyone to disseminate information. And finally, we need to support people's health literacy and how they can adhere to their own medications. So if someone has a chronic or multiple chronic conditions, they need to really know and be enabled to take ownership of how they deal with that. So one suggestion here, as well, is that we fund annual medicine reviews. So people do come in, they check in, As John Wenman mentioned earlier, this can be a kind of a contentious topic. So, making it proactive rather than calling people out for doing something wrong is really important here. To reach people, we need to make sure that access is equitable. So we need to remove cost barriers. Our research found that comparing countries across the G20, where governments pay for the greatest share of health costs, healthy life expectancy is highest. So that shouldn't really come as a surprise. We know that when we don't have those cost barriers, we are going to win out ultimately. So we need to make sure that things such as vaccination, screenings, preventative medications, and help to adhere to those really doesn't come with cost barriers. We need to target our interventions, so really make them about people, so working locally, but also with workplaces, for example, and making sure we're really developing in-home healthcare for people who might have mobility issues or other reasons to stay at home. And finally, we need to make sure this really becomes a life course priority. We still too often think about prevention being something that comes very early. And while it's important to start early, we also know that it's absolutely never too late to prevent ill health. So we need to make sure that things like vaccination have national life course programs, and the same for NCDs, and that actually the targets are really equal across all age groups. So we know, for example, that there are different uptake targets for childhood immunizations than adulthood immunizations, and there's really no reason that this should be the case. And finally, we've mentioned tech already, as well as data. We need to make sure that we're building on what's happened during the pandemic. So we've seen big efforts to make sure that we're actually linking up data, but the reality is that still it's in too many different places. Lots of the time it doesn't speak to each other, or not everyone can access the data that might be involved in someone's care. And most importantly, people themselves don't really know how to get it yet. So we need to be building on that, make sure we're enabling people to use it. So make sure that the infrastructure is there. And this can be as basic as making sure that people have wireless connections, but also that people have the skills and literacy. So be that individuals themselves that are going to use a new service, or healthcare professionals that are going to adapt to emerging technologies. And it has to be simple to use and accessible from the start. So we can't be developing services that lock more people out, because the whole idea really is to have this as a new avenue and an additional avenue for people to join. And we need to make sure we're getting the right solutions working. So we know there is no shortage of ideas in terms of tech. There are lots of things out there, but as Aaron mentioned, we need to be assessing this and have proper health technology assessment frameworks so that we know they're meeting the needs that are in the population, and that then once we have the right solutions, they have a quick path to actually be coming to market. So let's seize the opportunity, and I'm really looking forward to hear from our final panel as well, to think about what's happening at the moment, how we can make this move forward. We know that poor health isn't an inevitable consequence of an aging population. At the moment, we do seem to be heading that way, though. G10 done a lot to say that we want to invest in prevention, but now we need to see that actually happen and build on this window of opportunity. So back over to you, Kate.
Thank you very much, Lily, for that presentation. We're going to come now to a further 4 speakers for their thoughts. I'd like to start by welcoming Dr. Naokeyamamoto, who's the Assistant Director General for Universal Health Coverage and Healthier Populations from WHO. Welcome.
Thank you very much. Thank you very much for inviting me, and also thank you ILC to come up with such a comprehensive, wonderful report and outcomes. So I would like to very quickly, because I know that we really be behind time, so quickly to say 5 points short. I totally agree with that. The lady exactly said that prevention, health promotion part is less funded area in many areas, even in the WHO. That's why Tedros has already announced that his 5 priority area for his next 5 years term, if he officially elected, I'm sure, I believe. And the first priority is prevention, health promotion, address the root cause of diseases, and address the health determinant, the social determinant, and other determinant of health. This is at WHO number 1 priority. The headquarter, regional offices, country offices. Our division also need to lead it. That's a clear message to the world, the global level, and the regional level, country level. That's the one message I would like to deliver. Second issues, I heard lots about the, never to be late to intervene or to prevent or intervene to the elderly people or senior people. But at the same time, I really would like to highlight the intervention for the early stage of life is quite important. The children, small children, baby, that is very important in terms of like obesity. Children obesity should be prevented for the future, of course, continuously. But for example, like low nutrition or malnutrition for the young ladies, really need to come up the osteoporosis and fracture in the elderly stage. So we really need a life course approach at the country level. Third issues, but when we talk about the prevention promotion for the elderly people, really need to work with the outside health sector, beyond the health sector. And definitely we need to talk about the food, nutritious, affordable, safety food, or we need to think about the safety designing of the housing, or we need to talk about accessibility of the transportation. Even in the city designing, we should be safe and accessible for everybody, that is especially for the elderly people. So that is, we need a whole society approach, but sometimes this takes a time. So we need to advocate now, but many countries will face the big demographic change. Some country has already aging society, but others, but it's coming soon. So we need to share the experience, how to design society. First is, I would like to mention about ageism. You know, sometimes, you know, people, even in the medical professionals or aging elderly people himself or herself, has some different image or stereotyping image, what aging people can do or cannot do. Even in the rehabilitation service, for example, in the medical care, some medical care may have some underestimated what the elderly people can do or achieve. So we need to think about it, the possibility, opportunity, and the huge capacity of the senior person. And we need to support them. This is a force. And finally, I would like to add more research. Definitely, we need more research in global community, including social research, but science, medical research. I heard the previous speaker talk about adherence issues. And he mentioned about, I'm sorry I missed his name. He mentioned about we need more tailor-made the treatment and the medical control of the clinical condition. But I also would like to add that we may need to clarify about what the treatment or medicine we really need for elderly. Sometimes we prescribe unnecessary medicine or drug, which doesn't have any strong effect or positive impact for the person. So tailor-made approach. Also, we need more research for the medical and PHC, medical care and primary health care for elderly. That is I would like to emphasize this. But looking forward to working together as always. So thank you very much for inviting me. Over to you, moderator.
Thank you very much for that. Really appreciated. I'm going to move on now. I hope she's available to Professor Annalise Welder-Smith.
Thank you, and really thank you for inviting me, and congratulations to an excellent report. As a disclaimer, as you see, I'm an infectious disease specialist, and I will use today the lens of the COVID-19 pandemic to emphasize how to deliver vaccines to older persons. And I will not only use the lens of the UK, but also the global lens. Next slide, please. So indeed, the COVID-19 pandemic has really unmasked the need to vaccinate older persons, not only to vaccinate them, but also to have processes in place to actually deliver, to really deliver it to them. So as you all know, I don't need to tell you, older persons are at a higher risk of severe COVID disease outcomes. And the primary objectives throughout the whole pandemic has been to avert deaths and protect healthcare systems. And this can only be achieved by first achieving high vaccine coverage rates amongst the very old and older persons with comorbidities. And really the roadmap that WHO developed really re-emphasizes this. to first have high vaccine coverage in these highest priority use groups before, and including boosters, before even moving down to lower priority use groups. And the lowest priority here are adolescents and children. Now, unfortunately, many problems during the many countries had problems in accessing the older persons, and then went for the lower hanging fruits and vaccinated younger adults and adolescents, which is exactly what we did not want as a policy for the pandemic. And unfortunately, this particularly happened in lower to middle income countries. Countries like the UK were actually exemplary in rolling out the vaccines in the very old first and then going down. And it's really from the UK that we should learn how to access and roll out vaccines to older people. And the UK used an existing system, which was the influenza vaccination program for the elderly. And so it's really a notable example from which we need to learn. Next slide. This is a busy slide, but it's important for you to understand really the magnitude of the proportion of older persons and persons with comorbidity who are also usually older, to really calculate also the number of vaccine doses needed. And this is a busy slide, but I want to draw your attention to the very low, to the lower rows here to show you how high the proportion actually is. And it differs from region to region and is in the lower, if I take 60 years as a cutoff, is in Africa, it's 18%, in Asia, it is 28%, in Europe is 39%. And so worldwide, it's about 27%. So this is a sizable proportion of our global population for which that we need to target to get the COVID-19 vaccines out. And here we really want close to 100% coverage. Next slide. So really the lesson, I think, from the pandemic is that we just cannot start with vaccination programs from scratch during a crisis. The processes have to be in place, programs must be in place. And so hence, we need to re-emphasize the absolute urgency of the life course approach to vaccination. And the issue is, as you all of you know, especially also in the public eye, vaccinations are for children. But there's more and more evidence to support a life course approach. That means from children to the very old, so giving vaccinations through all phases of life. And a life course approach requires that you have schedules, but you also have access, you have availability, and it's adapted to the needs of the different age groups and their different vulnerabilities, also different risks to infectious diseases depending on the age group. Next slide, please. So taking a life course approach offers several advantages. It's an opportunity to improve overall population health, in this case with a focus on the elderly, support health system sustainability, and promote economic prosperity. So really the whole idea is to promote healthy aging, to alleviate the pressures on healthcare systems by at least averting vaccine preventable diseases. So there's a lot of socioeconomic benefits, including possibly increasing the workforce lifespan in our population. And vaccines by themselves are always the instrument to achieve equity and is part of universal access. And lastly, and we often discuss it, it's also to reduce the spread of antimicrobial resistance. Next slide. So how do we do this? And we're now focusing on the elderly or the older persons. So we really need a comprehensive immunization program to ensure vaccine availability for the whole life course. The policies, the recommendations, of course, must be evidence-based, but there also needs to be a reliable vaccine supply chain in place. we need to enhance public demand for immunizations, not just that we have the evidence. The public needs to want to be immunized. And here we do have problems with the awareness that is lacking in the older age groups. And also there is still an absence really of awareness of the need for immunizations, beyond COVID-19 in older persons, also in civil society organizations, but even, you will be surprised, even in healthcare professionals. So we also need to retrain healthcare professionals to include educating their elderly patient population for them to understand why it's important to take up immunization even when you're older. And just as an example, we are now almost at the end of the pandemic. China, Hong Kong had a relatively high vaccine coverage rates amongst the adults, but now Hong Kong is seeing a lot of deaths because they failed to vaccinate the older people. And it was not a failure of the system, it was a failure of the acceptance of older people to accept vaccines. Next slide. So what are reasons again to immunize older people? So of course, lots of medical reasons. You prevent unnecessary hospital admissions. You can reduce the case fatality or the mortality from vaccine preventable diseases. However, there's one problem, is although the older really benefit most, they have a lower response to some of the vaccines, which makes the case to even start the vaccination earlier when they're in their adulthood rather in their senior extreme of the age curve. So really to start earlier before the immune system begins to decline. We also need to know, again, older people have more chronic conditions, so they have more underlying comorbidities that predisposes them to more severe disease. And so it's really also addressing those complications. And lastly, again, to protect older people, because the direct vaccine protection is sometimes suboptimal in older people, is to re-emphasize the need for caregivers or family contacts around the elderly to be vaccinated to indirectly protect the elderly population. Next slide, please. So I just want to remind you, there is a World Immunization Week coming up this month, 24 to 30 of April, and we really need to message. It's a long life for all. We need to move away from just childhood vaccination to the whole spectrum, from adolescent, and then another group is the pregnant women, to adults, and then to the older adults or the elderly. We need to message priorities on the safety, effectiveness, the equity issues, and diseases prevented. And some of the diseases and vaccines needed are different in the elderly. For example, herpes zoster, or the need for influenza or pneumococcal disease is more in that age groups. And so the lead line is in pursuit of a long life, well lived, and here are the hashtags for the World Immunization Week. Thank you so much.
Thank you, Annelies. Really, really important that you're highlighting the importance of lifelong immunisation there. Thank you. I'd like to come now to Dr. John Beard, who was previously the Director of Ageing and Life Course at the WHO.
Thanks, Kate. And I mean, first of all, I'd like to congratulate you all on the reports. I think it's fantastic to see the ILC keep the issue of prevention on the global agenda. It's so important. And also within the reports, I really like the emphasis on inequities, which Garth also spoke about earlier, the focus on life course, and looking at systemic issues like funding models, about how can we encourage the development of systems that actually achieve the things we're looking at. Having said all of that, I think that historically prevention, while it has been an important topic, our focus has always been very narrow. People have particularly looked at NCDs, and the prevention of disease. But if we're thinking across the life course, it's really important to think about not just the prevention of disease, but the prevention of the consequences of disease, how we can prevent the declines in cognitive and locomotor capacity that occur as people age, and also how we can prevent people falling into care dependence. And so I think it's really important the way that the reports have reinforced thinking about these issues from a systemic focus, and particularly the issues of workforce, IT, and integrated care. I know my time's short, but I'm talking towards the end, and so I thought what I might do is just throw a few ideas out there for maybe your next report or people's thinking about the future anyway. The first one is that I think we talk about person-centered and integrated care, and it's great to see that emphasized in these reports. What I think we're also moving more and more towards is personalized care. Each of us have different physiological state, we have different genetic inheritance, we have different circumstance, and we need to tailor our advice and our interventions to each person as an individual rather than providing generic guidance. And I think that's part of the reason why a lot of interventions in the past have been ineffective. And it's also part of the reason why we end up with the unnecessary care that Naoko spoke of a little bit earlier. Because not everybody needs a treatment for a certain intervention. What we need is much more coordinated and personalized care that really understands the individual. One of the things that's going to help us achieve that is ICT. And I think as we can start to monitor people's health much more closely and continuously, as we can understand more about their activities, then we can actually tailor the guidance and the messages which we give people. And also this can help us, this ongoing monitoring can help us personalize the care that we provide for them, so the care and support. And finally, I think what we're getting to is a really an amazing time in healthcare where we're starting to move beyond thinking about health problems through the lens of disease and looking about the underlying complex physiologic changes that occur across the life course and what we can do to actually intervene to ensure that those changes occur as slowly as possible. And so that will allow us to maintain our functioning and also allow us to reduce the risk of the multiple chronic diseases that occur in older age. So I think thinking about how we can monitor those underlying changes and then tailoring perhaps some preventive activities to help us maintain the best possible physiology underneath all the more observable changes which occur in older age. I think that's going to be a very exciting thing for the future. But I think it's they're great reports, and it's terrific to be here and see the work you're doing.
Thank you, John, and for your comments there, much appreciated, and some really interesting ideas that maybe in the panel discussion we could delve in a little bit more into. Finally, I'd like to come to Carolina Socha-Dietrich, who's the Senior Health Policy Analyst and previously of the Health Division at the OECD. Welcome.
Good afternoon, and thank you very much for the invitation. I would like to also congratulate you on both reports. And as I'm the last one to speak, I would like to circle back to one issue which I find central for lots of this discussion, which is the adherence, because of course we tend to focus on convincing the payers to invest in prevention. And let's say we succeed, we have all the preventive measures in place, funded, and have professionals needed to deliver them. But then it's all labor lost if the patients don't adhere to these preventive therapies. And then, of course, comes a big question, which was already mentioned a number of times: what drives non-adherence? And I think it's worthwhile to recognize that a lot of adherence, or as important as a lot of adherence is intentional. So we frequently talk about patients who forget or otherwise during their daily routines don't manage to follow the therapy. But in fact, more often than not, patients consciously decide not to adhere to a treatment. And the main driver there, the evidence suggests, is the health system. So we can say we have the adherence by design. So if we forget about it, then we can't make progress. So a few examples of why this happens. I don't want to talk about co-payments for drugs because in many G20 and OECD countries, these co-payments are low or none at all, but rather about how cumbersome it is for a patient to contact the health system, to make the journey through the health system. For chronic conditions or preventing deterioration in a chronic condition, the patient takes medicine for years and decades. And if the refilling of each prescription is something which takes a lot of time and is difficult and unpleasant, many patients might stop the therapy too early or not start it at all. And it's still in far too many countries, the patient always has to make a physician appointment with a physician to refill a prescription. This might take a few minutes, but it means also traveling time. And in primary care and out office-based specialist practices, the scheduling of appointments is very rudimentary. So if one arrives in the afternoon, it might sometimes mean waiting for an hour or two because a lot of delay accumulated since the morning, and so on and so on. There are services sometimes designed to help elderly people to move more, engage more in physical activity, and they are referred to the services, but without thinking how are they going to get there, because many of these people might not be driving anymore or living in an area where there is not a very flexible public transport. Here I would like to go back also to COVID-19 and the vaccination strategy. At the very beginning, most countries opened these big vaccination centers, but not many focused on the question, how are the elderly going to get there? And especially as many of them were afraid to leave their home. So that's all this makes very difficult for patients to follow the recommended preventive or curative treatment. What was also mentioned here today a lot were imperfect electronic health records, which we have now, but they are incomplete. So there are electronic health records at the primary care level, separately at the hospital level. Yet another area of electronic health records is at the office-based specialist care. And it's still far too often down to the patient to be the link to carry the missing information to each practitioner, either on paper or in their head, and the patients perform this function better or worse. Sometimes it makes them feel that the health system doesn't really know anything about them. And of course, then they might question the therapy, might lack the motivation to follow it. It also gives problems in coordination of care for people with several conditions. They might feel really not well taken care of. Sometimes it's only at the pharmacist when they present a pile of prescription that the pharmacist raises an eyebrow and asks whether they have discussed with their general practitioner all that. And well, then it's still again only down to the patient to book another appointment with a GP to discuss it. And the question is how many patients do that, how many patients give up at this stage. Then we also have, as already said many times, health professionals who are frequently overburdened, who might not have time due to the way the visits are organized and reimbursed to go through the process of shared decision-making with the patient about the therapy, to adjust the therapy to the patient lifestyle. We have length of professional life extending, so more and more elderly people are still fully professionally active, and the therapy, the dosing regimen, the intensity would need to be adjusted for that, but there is no time to do it, or there's lack of some decision tools which would help doctors guide this discussion with patients effectively, time-wise especially. As already said before, there's also some need for cultural change, because still there are health professionals who don't think that this kind of discussion belongs to their job description. So in sum, one can say that the non-adherence is an indicator of how well the health system prevention or curative care addresses the needs of patients. And if we follow these obstacles patients face in each encounter with the health system, then we find out where to intervene and what to do better.
Many thanks, Carolina. Some really interesting, important reflections there on the opportunities about addressing adherence in particular. So that's it for our panel discussions. But I'd like to move on now to a group discussion where I'll be inviting all of our panels to come in on some questions that people have been putting forward on the Q&A function. Before we do that, I would like to welcome you all to just take part in a second poll that we're doing. If we could just jump to that slide. Just gives you a chance to have a think. And again, it's really, really easy. Slido.com, 1 to 7. And then what can I do to promote prevention in an aging world? Just to clarify, we mean you and not me, myself. But have a think, and just over the next 20 minutes, if you can, put something in there, and then we'll come back at the end for some closing remarks. Great. So I'd like to come to first a question for the whole group. I'd like to start with our first question from Teresa, which is what do you think the metrics that could be used would be for capturing the full benefit of delivering prevention in an aging world? So that's what sort of metrics do you think that we could be using to fully capture the benefits of prevention? Does anyone want to jump in on that?
Yeah, I'll jump in. You know, I think ultimately we have to always have our endpoint morbidity and mortality. I think certainly in public health and in clinical world, we use parameters and surrogates along the way. But ultimately, our goal always has to be to have individuals live their most productive, and potentially lengthy, but certainly productive life. So I think, you know, issues around functionality in terms of morbidity and mortality, I think should always be a spectrum of our endpoints of measures.
Can I just come in there, because I agree, but maybe have a slightly different twist. There are plenty of older people who report being in good health, but many of the people who report being in good health actually have multiple complex conditions, but those conditions are being managed well, and they are undertaking the sort of behavioural, the lifestyles which enable them to maintain functioning. They might live in a supportive environment. So yes, of course, we need to monitor disease and mortality, but what to me is really interesting is not just the prevention of disease, but monitoring whether we are preventing functional declines, as Garth says, so cognitive, locomotor capacity, and so on. And also looking at how people are able to maintain those capacities despite the presence of disease, because that tells us something different. That tells us whether when people contract a disease, whether they're receiving the appropriate care for it and whether they're living in a supportive environment. So I agree, but I'd like to see it more complex than has generally been the case in the past.
Thank you, John. Can I come to Naoko next?
Thank you very much. Also, I just would like to add the mental health issues as well. I'm sure we talk about health is mental health, physical health, all health, but I just emphasize those issues. Also, like a loneliness, isolation in the society. That kind of all issues should be need to include it when we talk about elderly, especially for the elderly, not only the elderly people as well. Thank you.
And Sean, can I bring you in?
Certainly. Perhaps to not answer Teresa's question directly, but to add to what the others have said, it's important to be able to start a measurement process, but then also to measure change or rate of change over time as well, setting out a number of key metrics and then progress towards goals. If I use an example that might compare across member states, if there was a 1 to 10 rating scale on certain measures, a change from 0 to 1 for one country should be considered as good as a change from 7 to 8 on another, because it's actually measuring progress. Clearly, if one country is a long way down some form of measurement metric, that might be poor relative to others, but relative to themselves and that change, any change is good. So what is the rate of change over time towards outcomes?
Great, thank you, Sean. Any other thoughts before I move on to the next question?
And if I jump in, Kate,
Yes, please.
I guess as well in terms of our report, obviously we had some metrics in terms of how we measured things. And I think when we talk about, I think what John mentioned is really important as well as actually people's experience. I think when we're talking to governments, perhaps while it's very simplistic, also the economic metrics of how much things cost and actually making the really strong argument that, you know, investing in this is bringing a big economic return can be a helpful sort of additional marker. But I think we should, you know, make sure that the most important still stays people's actual experience.
Great, thank you, Lily. I'll come to Julie and then John.
Yep. So, so this part of what John was talking about is what I'm talking about, that long tail of prevention. So even when people have some decline in their functional ability, there's a lot you can do to either move them back up or get some selective optimization or substitution or environmental or other supports for people. And all of that can still help people have quality of life, relationships, participation, growth, all of those things. And I think we have to be, so we do have measures and metrics like disability-free life expectancy, but we do have to be fairly careful not to be ableist about it and ageist about it. So I often think about this, if we talk about disability-free life expectancy, and then I look in the audience and there's someone in a wheelchair, and I know that they could be living a really great life. And so, you know, I think we have to be careful not to be ableist and not to be ageist, and to recognise that despite our best efforts, as people age, they will experience some changes in how their bodies work. And we don't want to write that off. We want to be able to say you can actually still have good quality of life right through to the end.
Thank you, Julie. And John?
Yeah, I mean, I'm not in disagreement with anything anybody said, but I think what we often lose sight of when we go for metrics, and we're being asked to think about metrics to judge the success of innovations and policy, is the whole question of social inequality. And I think often we lose that when we look at just overall levels. I think the gap between the outcomes for the richest and the poorest, or between different age groups or ethnic groups and so on, I think that absolutely needs to be at the top of the metrics pile, as it were, because they're the things by which I think we can judge how well we're doing, as much as raising the level of all individuals, but just reducing the gap between the richest and poorest, or whatever groups we're looking at in terms of social inequality. And I think never lose sight of that.
Lovely, thank you. And Aaron? You're on mute, Aaron.
Sorry, I'll be very quick. I just wanted to add to what John said, because I think his point about inequalities is really important. And I think particularly for developed countries, the biggest gains in health outcomes we're going to see are from those that are who have the poorest health outcomes. And so if we really want to see, for instance, in the UK, an increase in 5 years of healthy life expectancy, it's going to be from those groups of the population where we're going to actually see that increase in healthy life expectancy, not those that are already benefiting from access to health services and not negatively impacted by wider determinants of health as well. So that was all for me. But.
Wonderful, thank you, Aaron. I'm going to move us on to our next question, which again I think is for everyone, so please feel free just to jump in. How do we balance the need for prevention and urgent care and long waiting lists for services? Does anyone want to jump in on that? Julie?
I think they're the same goal. That, you know, if it's no good having long waiting lists for things like cataract surgery or knee replacement or diabetes care or antenatal care or any of those things. So, you know, I think they all have to be part of the same goal. And I think we really need to rethink our healthcare systems so that they're much better integrated and treating the person holistically and across the life course, so past, present and future. So I just think if we're thinking it's that or the other thing, we've got it all wrong.
Great, thank you. Anyone else want to jump in on this one?
Yes, I would like to say that actually, yeah, for example, at the OECD, we've done a lot of work on the so-called tackling of wasteful spending on health, and there, through preventive measure, one can save on unnecessary curative care, which wouldn't occur if the preventive measures were in place and patients adhere to them. And as such, then we have resources which can be better used in the health system for example, employing more professionals, which can allow us to cut down waiting lists for certain surgeries which cannot otherwise be prevented.
Yep, great. Naoko?
Thank you very much. I should say 2 points. When we talk about prevention, this is prevention, whatever. So if the prevention wording or meaning for the young people may be different to the senior person. Because when we talk about senior person, they always talk about their health issues, and many health issues very important for them. And also they have some experience to the chronic disease control management, or some friend has some disease or some experience to go to the hospital so often. So how we can describe and communicate with the senior person in terms of the prevention word. And this is also, I always think about that our health professional, public health worker, but other people need to be defined and also tailor-made communication, as my colleagues, John said that, but we need to think about it. Second issue is, as I said at my speech, we need to work with other sectors clearly. For example, many senior people working in many places. So working environment to prevent injury, that's very important, or traffic system to prevent a senior person's injury or accident, whatever. That's also very important. So definitely, when we talk about the prevention, we would like to change approach to the society and the health social system as well. Thank you.
Thank you very much. Any other thoughts on this question before I move on? Great. Apologies for the storm outside, by the way. I hope there's no background noise. My next question is probably more relevant to talks about vaccination and adherence. So what role does trust play in vaccination uptake and adherence, and what can be done to build trust? Does anyone want to come in on that? John in particular, and Carolina. John. You're just on mute, John.
Apologies. Yeah, I mean, trust is clearly crucial. You know, there's this distinction now made between, you know, vaccine sort of refusal, vaccine hesitancy, and so on. You know, there's sort of various categories of people who don't want to be vaccinated, but clearly one of the things that emerges from the reviews of people who are either unwilling to be vaccinated or unsure about being vaccinated is the issue of trust. And trust occurs at about 3 levels. One is in government levels, and I think some governments have proved themselves more able than others in providing trustworthy messages about the value of what they're doing. Trust in the pharmaceutical companies, there's still considerable suspicion there. And obviously trust in the healthcare providers as well. So at all 3 levels, trust is crucial. There are certainly other factors which are influencing people's unwillingness to be vaccinated. but trust is right up there. In terms of what one can do, it's quite difficult because quite a lot of the damage has sort of been done and obviously continues to be done through social media, unfortunately. So working with the large social media companies to try and combat misinformation, fake news, all of that stuff is obviously going to be helpful. But I think in terms of, certainly some of the community out there, the damage has been done, and how one can reverse it is going to be tricky. And I think, the importance of, key opinion leaders. I think earlier, Aaron talked about, different group, or actually might have been UK, about people like faith groups and so on, smaller units in the community that people actually do believe in. I think, it's going to be probably through those sorts of networks that we're going to try and be able to re-engage with people. But it's a hugely problematic area, and in a way the genie has got out the jar, I think, in many ways.
Thank you, John. I'll come to Sean and then Aaron.
Perhaps 2 points. One on the social media side is that in any particular search engine that exists, the information is largely unfettered by evidence. We have to scroll through looking for the evidence-based sources versus the opinion sources. And from a health perspective, if people could have access to relevant and timely information where they knew was an effective source of information or was somehow verified as trustworthy, I think that's a very helpful start. The other point I'd like to make in terms of trust, and it goes beyond vaccination, it's inclusive of it, is that, this was raised before, we do have a sickness-based model as opposed to a health-based model. And if we reframe this discussion around adherence, preventive health, etc., as one that helps us think about a longer and a healthier life, as opposed to thinking about what am I about to be given for my sickness, then people may well come at that with a different mindset. To give a great example, my mother wouldn't think that she has osteoporosis and frankly denies it. But if I ask her whether she cares about bone health, she is totally there on it. And it's just a simple reframing of a message. This certainly has a behavioural psychology dimension to it. So how do we encourage people to focus on addressing their own health and be able to consider that as opposed to sickness? It could be a good start.
Thank you, Sean. Aaron.
I just wanted to add, I think there's something to be said about looking at representation across healthcare professionals, particularly in areas where they're overrepresented by groups that don't actually live in that area. We need to make sure that people within those communities can actually relate to the healthcare professionals as well. And I think that's one way in which we can look at sort of representation, particularly in particularly diverse countries, looking to ensure that, healthcare professionals sort of represent the groups for which they serve. And I think there's, kind of a significant way to go in that. But if we do that, I think that can help to perhaps address trust barriers at the individual level, and at least kind of encourage people to walk through the doors and engage with their healthcare professionals. Don't think that's the full answer, but that's certainly part of solving the problem.
Thank you very much. If anyone else has any comments, just jump in. Otherwise, I'm going to go to a final question. But I think this is a really interesting question. So I'd like to go round everyone in turn, actually. So the question is, what could we each do to drive forward an agenda for change? So this comes back to our poll question, but really trying to, as much as we can, think about us as individuals and our organisations. What can we do to drive forward the prevention agenda? So we'll come to the poll at the end of the discussion, but would anyone like to come in first? Garth?
Yeah, I think ownership, in various industries, various sectors, at various levels, not just kind of with the folks tasked with the job, is probably a good first step. I think awareness, ownership, engagement, commitment is probably an initial start to trying to broaden the scope of folks who are committed to making a difference on this.
Thank you. Very good point. Anyone else want to jump in? John?
Yeah, I completely go along with that ownership issue. It's a constant struggle. We do a lot of training for healthcare professionals around prevention, particularly around adherence, supporting adherence. And the initial point of resistance, not my problem, it's somebody else's problem, is huge. And I think the OECD report and actually your own report brought that out really clearly. So turning that around, looking at me, what I can do, which I think was your challenge. I think, what I can do in the role that I have is training both in awareness, but also training in providing tools and skills for people to really engage in that area once they take it on, once they own it. So, 2 crucial steps.
Brilliant, thanks, John. Julie, next.
So I'm doing something locally in my area. It's called the Hunter Aging Alliance, and it's a group of individuals and organisations. So we've got about 150, mostly individuals, but some of them are very large organisations that have agreed to look at what we can do in our community to make it more age friendly, following the WHO principles, but creating a community where older people have more of a chance to participate and they can age well. So it does have very much a health promotion focus. So we are looking at exercise, we're looking at housing, we're looking at all sorts of things that older people can do. So I've started off by working with the councils. So we've been working together to identify some low-hanging fruit that we can do straight away, some things we can do with just a small tweak, and then some harder things which we'll have to work towards but are important to keep on the agenda. And then trying to look at some of the other groups and look at what's happening for older people and how we can improve the way services are provided, that both dementia care and long-term care in the first instance. So we actually have quite a front of activities. We've probably got too many activities at the moment for what our capacity is, but we're working towards it.
Wonderful, thank you, Julie. I'll come to John next.
Yeah, I've been working on the economic case for investing in healthy aging. And what I have to say, it's been really difficult because the evidence is really limited. So, and until we get the finance managers, whether it's of health systems or governments more broadly, until we get them to really buy into this agenda, it's going to be really hard. So I'm not going to do it myself, but I'm sure there are people on this webinar who can help build the economic evidence that investment in these areas is actually, there's a very strong return in terms of cost benefit. And particularly, I'd really like to see that focus on how on the impact of inequities and how interventions which target inequities can be more reinforcing than those which just are more generic and target everybody. So I would really look to try and build the investment evidence.
Great, thanks, John. And Naoko?
Thank you very much. So as because I'm in the WHO, so I just say some few words. First is advocacy in a global level. So decade of the healthy aging, as you all know, that it's a good movement in the world. It's a global level, regional level, especially with the in the course of the decade of healthy aging. We collect the voice of the elderly people, what they would like to do, what they can do, and what they asked us to do. Second issue is data and evidence, as John mentioned a little bit, but not only economic part, but also we would like to collect the data. But third is what we can do is share the country experience, because there are lots of good experience at the community level, local level, some government level, not only the small health sector, but all many issues like a social security, pension, environment. And we have lots of great leaders for the elderly, including women and gentlemen. So we like to collect such experience, share with them, learn each other. WHO can coordinate to facilitate the expand potency. Thank you.
Thank you very much. Anyone else have any last thoughts on that?
Yes, I would like to say some things from the OECD side again, especially referring to what John has just said, that it's the financing where probably one has to start. So in the whole portfolio of efforts one can do to make the health system concentrate more around the people and patients instead of diseases and provider groups. Probably the starting point, the key lever to improve things is to make the ministries of finance participate. This is, of course, there where we talk about, there where we have public funding, but that's most of the countries in the OECD. Actually, we have a group where twice a year representatives of ministers of finance and health, ministers of health meet, and there are difficult discussions, but there's hope for progress, because sometimes we find out that the ministers of finance have no idea how the budget for health is actually decided in detail. So, I mean, they know more or less how much it is. They always try to make it less, but they don't know that, for example, in many countries, we still are having hiccup from the times where the budget was decided by the number of beds, not by what's done to the patient and how effective the preventive or curative services are. So there, with this big surprise, big aha, opens a nice opportunity to change that, to make it better, to pay for health outcomes and to concentrate on patients and what they really need.
Thank you very much. I'd like to move now to the results of the poll, if it's possible to show the results there. Great, interesting, very interesting. Does anyone have any sort of initial thoughts on the results of the word cloud there? Do you agree? Do you disagree? I come to
and I should say I've been getting a little sneak peek of people's responses coming in, and I think just from ILC's perspective, I think this is really where we want to be coming in with our next steps. And I know, Kate, you'll be sharing a little bit about that afterwards, but I think just to say, you know, a personal thank you to everyone who's joined us on the call today, on the panel or not. We're really excited to be, you know, working alongside all of you, alongside hopefully the Decade of Healthy Aging and all the important initiatives that are going on. And I think, you know, in our next steps, we want to be making sure that we go from, you know, our policy recommendations to really seeing some actions and hopefully spreading the word and collaborating. So I think in terms of our ambitions, this is very much what's sort of mirrored on the word cloud here.
Lovely. Sean?
Thanks, Kate. I know we're heading towards the end. I would like to say, as I reflect on the word cloud here, that one of the reasons we were very pleased to support ILC in the doctor's orders report is to move the blame away from individuals with respect to adherence and actually make it a systems level issue. Carolina's report has been excellent in that regard to point that out. And as I look at the word cloud, I see words like advocate, collaborate, join forces with like-minded stakeholders, spread the word. All of those things are very central to this idea that collectively we can ensure that we support individuals to take the best possible approach to their health. And maybe, Naoko, just to say one thing about the Decade of Healthy Aging, I also, as someone who's on the way to aging but not aged, I also see the Decade of Healthy Aging about people being in this type of age group, taking a life course approach to their health. And how I see the system for me when I'm 70 or 80 years of age is somewhat of a reflection of how I think we are talking today as well. What system do we seek to create to maximize outcomes for people to age well? So thanks, ILC, and thanks to all of the participants today as well.
That's some lovely closing remarks, Sean. Thank you. Anyone else for some last thoughts? Aaron, I might just come to you for your thoughts on the word cloud there.
Yeah, I mean, I think it's encouraging to see that collaboration is something that I think we've tried to implement throughout all the work that we've done for the prevention program. I think for me, one of the key bits of focus, and I think, other speakers have kind of said this already, is to kind of engage with engage with people that aren't sort of that sure, but kind of get people who are like-minded, but also trying to encourage and trying to start that conversation with people who haven't already engaged in prevention, because I guess there's always a worry, not just in prevention or health, but in all the work that we all do as policymakers, that we're speaking to the people that already agree with us. So I think, how do we get outside of that sort of I guess in a way sort of that siloed group of people and kind of encourage people who can actually really help support the prevention agenda, but might not be aware of it or might not see how they might be linked to it. So that would be something I'd like to kind of consider more more deeply as we kind of move on.
Thank you, Aaron. And I suppose I'm just going to just give you a little bit of information now about the next steps of the Delivering Prevention programme. And I suppose it's an answer to the challenge that we set you all, what can we all do to drive forward the agenda? So we've been thinking a lot about the last 2 years of the prevention programme, and Aaron and Lily have done a fantastic job in running it and writing the report. And they've really developed an interesting idea for how we will take this forward into the next year, but in the next following years. So we're thinking about calling it the Global Health, Wellbeing and Prevention Index. And it's really got 3 aspects to it. And we think it's important to share this today because it really does resonate with, I think, a lot of the things we've been talking about, but also sets the agenda for what we intend to do going forward. That we think it's important to continue to make the case for prevention, that we want to hold governments accountable, that we want to use data in a way that shows prevention alongside health and well-being, but also alongside mortality, morbidity, quality of life, work span, which tries to sort of look at prevention from a holistic point of view, which we think is extremely important. We want to continue to engage with policymakers across the world, and we want to build a coalition of the willing. So we want to use this index, this tool, as a way of being a catalyst for change and continue to engage. So today is really important for us. We were really excited about launching this work today, and it's also a really exciting platform going forward. So just next slide. A really big milestone for us going forward as well is our global summit, Delivering Prevention in an Aging World, of which immunization will be a big part of the few days event, taking place between the 6th of June and the 8th of June. We're having it in France, but in terms of virtual access, we're opening it to all. So I'm letting you all know now that this event is going on. We will be sending out invitations at some point for that virtual access. But again, it's really exciting. It's a way of us, as Aaron just said, trying to engage those who are experts across the world, but also who are maybe haven't engaged in prevention until now. So a really exciting event for us going forward. And I suppose just to finish, I'd like to thank everybody for joining us today. A fantastic and really engaging discussion, some really interesting questions. Thank you all for submitting. And the poll, wonderful reflections on that as well. So thank you very much. I'd like to just finally mention an upcoming event that we have called Vaccines and Vacation, the role played by immunisation and getting tourism moving again. So that is a virtual webinar taking place on the 10th of May in a few weeks' time. Wonderful, thank you so much. We're finishing a little bit early, which is great, gives you a few extra minutes free time. So again, I'd like to thank you to the panel for your wonderful contributions today, and thank you everyone for coming.